So, today's class is going to be on autoimmunity. It is one of the cases where the immune cell actually rebels against the host, and what you have is generation of an immune response against host cells which hurts the host. Now, under most cases the immune response is directed towards pathogens, tumor cells and so on. It is to help protect the host, but in some cases the immune system goes awry and then attacks itself, and in this class what we will try and do is try and understand the mechanisms around it. So, if you see in the first slide, Barnett, the famous McFarlane Barnett, when he coined the clonal selection theory, one of the tenets of the theory was that dealt with the fact as to how come the host cells are able to protect themselves from receptors that might recognize self, and this was dealt with the aspect on tolerance, whereby immune receptors against self would be eliminated, so that the host does not generate a response against itself. Now, we know that by and large the immune system does a good job of protecting itself, but however in some cases the immune system turns itself upon the host, and that is what this class is all about. So, basically autoimmunity is defined as a breakdown of mechanisms responsible for self tolerance, and that is the essence of autoimmunity. So, how does this occur? And so we will try and figure it out. The other aspect is what are some examples of autoimmunity, and I am sure if you look around your own family, your own friends, society, you will see these cases quite glaringly. One of the first one is arthritis, especially rheumatoid arthritis, where you have generation of immune system has gone bad and attacks the joints especially. So, you have inflamed joints, and people are unable to function properly. So, how does that occur? We will be studying that aspect. The other is type 1 dependent diabetes. Now, if you remember, in terms of diabetes there are two types, type 1 and type 2. In type 1 is the insulin dependent diabetes. Over here you have immune cells that target the beta cells of the pancreas and kill the beta cells preferentially, as a result of which insulin is not produced, and since insulin is not produced, the blood sugar levels are very high, as a result of which leading to diabetes. In type 2 diabetes insulin is there, but they are not responsive, the insulin receptors are not responsive, as a result of which glucose does not get pumped inside the cells. So, the diabetes that we are talking about is the insulin dependent type 1 diabetes. Then the other example is systemic lupus erythematosus, a disease that often afflicts women, and this manifests itself after they turn about 25 years of age, so on. So, and if you look around, and we will be studying more diseases, and we obviously can't study all autoimmune diseases, but at least some diseases we will be studying in somewhat greater detail. Okay. Now, the other interesting aspect about autoimmune diseases is that there are high titer of antibodies that are produced against self, and despite this their ability to react to pathogens and all is compromised, and it would seem as if their entire effort, or the entire in these autoimmune patients, is directed towards immune responses against self. So, clearly if such a lot of effort goes in generating immune responses against self, then some of it is compromised, and especially the person becomes more susceptible to infections because the immune receptors and the mechanisms are sort of directed towards self versus and when such situation occurs, it does not help because a direction against non self also gets affected. Now, in the process of generating immune responses, it is possible that in some cases a small minority of these immune responses are directed towards self. In fact, when 600 monoclonal antibodies were studied against different viruses, it was found about 3% of these monoclonals also cross reacted with normal tissue. So, it tells you that this occurs, but as I said, there are mechanisms in place by which the host manages to keep these these autoreactive immune cells under check, and so they do not actually manifest themselves in terms of disease. It is only in rare cases that the immune system, as I said, goes a little bit awry and you have a reaction that manifests itself in terms of a disease in patients. So, but since this does occur, it is very important to study as to why this happens, and therefore, one can take preventive steps or therapeutic applications can be found out, which can sort of keep these in check, and these are very well studied by now. So, how does one determine whether a person is suffering from autoimmune disease or so? Usually in terms of theoretical scenarios, it would require replication of the disease manifestation by transfer of a particular antibody or transfer of T cells. But in general, the presence of an auto antibody, as for example rheumatoid factor in case of arthritis, or clinical symptoms, lesions in the brain, etc., are taken as diagnostic measures. So, for example, in rheumatoid arthritis, as mentioned, you have detection of rheumatoid factor by ELISA, and in case of systemic lupus, you have antibodies to nuclear antigens that are diagnosed. Now, what happens is, once you have this auto antibodies being produced, or you have T cells that start recognizing self tissue, there is damage. There is damage because you have an inflammatory situation where both innate and immune cells come together, and especially with antigen antibody complexes, you also have complement activation, which will further result in lysis of cells. You have a macrophage activation, and basically it results in immunopathology, and that is what it results ultimately in terms of a disease. And once you have that, then it is a question of trying to control this and trying to reduce this. So, in order to be able to do this, we need to understand the mechanisms by which all these occur. Now, in terms of classification of autoimmune diseases, there are two broad classifications. So, first is systemic. Systemic is that means it is all over, it is all in different organs, different sites. For example, in rheumatoid arthritis, you have it in several joints, often knees, fingers, elbows, so on. Systemic, and then you have systemic lupus. Well, systemic lupus erythematosus, again you have it afflicting different parts of the body. But in systemic lupus, especially, the moment it gets serious when you have antigen antibody complexes deposited in the kidney, and because of this you have the filtration is affected, your kidney function is affected. Once kidney function is affected, your health is at serious risk. So, you had one broad classification, you have the systemic, and the other you have the organ specific. And in case of organ specific, the one that comes into mind is diabetes, for example, and it is here where you have an immune response against your beta pancreatic cells which produce insulin, and so that becomes a problem. Then you have thyroiditis, where thyroid is affected, and gastritis, where the gastrointestinal tract is affected, and these are some things that we will be studying in this class. Okay. Now, how does this occurs? Now, there are several mechanisms proposed. It is not clear exactly what results. There is a whole list. There is a forbidden clone, altered antigen, sequestered antigen, immunodeficiency, genetic influence, and we will be studying these in a little bit greater detail. Okay. So, the first mechanism that we will study is the forbidden clone. Now, over here what happens is the clone has mutated post selection. There is some mutation or altered lymphocyte receptor has been generated through mutation, and because of this it now starts recognizing the host as foreign. So, this may certainly occur, because if you remember, especially in case of your B cells, there are somatic mutations that take place, and because of this it is possible that a receptor is generated which starts recognizing self tissue, and then this amplifies itself. Because of recognition, it will start amplifying itself, and this results and this may result into an autoimmune disease. The other scenario is an altered antigen. Either you have surface antigens or tissue debris, or antigens or molecules that are released by host by dying cells, and there is a link between increased number of apoptosis and autoimmunity, and this antigenic determinant may now be recognized as foreign, because usually it is kept it is not recognized because of this change that has occurred. It is now recognized as foreign, and you have a generation of an immune response against this. You have the other possibility is that you have a sequestered antigen. So, what a good example of a sequestered antigen is actually the eye lens. The eye lens does not come in contact directly with blood, but in case of damage, it would come in contact with circulation, and then you would generate a sort of a response against it. So, this would be a good example of a sequestered antigen. Then the other one is that of a immunological deficiency theory, which means as people age, the receptors become more and more. What has been found is that there is a narrowness or there is a limitation in the number of receptors that is observed in these people, and because of this you have increased number of autoantibodies and increased because the receptors that have gone so specific, perhaps because they are recognizing now some self tissue, and they sort of increase in numbers, and after a point they sort of can take over and generate autoimmunity. One of the major factors is genetic influence. Now, in some autoimmune disorders, it is clear that genetics plays an important role. So, for example, in case of rheumatoid or in case of some autoimmune diseases, MHC molecules predispose. So, the type of MHC molecule that you have predisposes you to be either sensitive or to be resistant to certain diseases, and this we had discussed during our discussion in MHC, and obviously the MHC molecules play an important role. Now, apart from these, there are other loci that play an important role, and these are some that we will be studying as we discuss different aspects in the class. Now, in terms of other factors, there are several other factors. So, one is the idiotype anti-idiotype interactions. Okay, this comes under the category of what is known as immune regulation. What is an idiotype? You remember the antibody molecule will recognize a particular antigen, and the part of the antibody molecule that recognizes this antigen is known as the idiotype. Now, because if you have lot of these antibodies being generated that recognize a particular antigen, you would have what is known as in terms of immune regulation, you would have anti-idiotypic antibodies that are particular to this part of the antibody molecule. So, often you have idiotype anti-idiotype interactions, and if you have a lot of this, what this means, you have antigen antibody complexes. So, you have antibodies reacting with antibodies because of idiotype anti-idiotype interactions, as a result of which you have these immune complexes, and if you have too much of these immune complexes, these are a problem, because as I said, these immune complexes are a problem in the kidney because they are harder to separate out. They will clump up and they will clog up the filtration process in the kidney. Now, the other aspect is molecular mimicry. Now, in here there has been a thought that often autoimmunity results after a particular infection. So, in this case what happens is, let us say you are exposed to a particular pathogen, and the body reacts to this particular pathogen, and some of these antibodies or maybe T cells that are generated also cross react now with a self molecule, because the the molecular pattern that is present in the microbe is cross reactive with something in the self, and this sort of results in it, and which is known as molecular mimicry, and this results in the generation of autoimmunity. So, these are the different factors that have been proposed. The other is determined spreading. Now, what do we mean by that? So, you have a particular determinant and you have an antibody response to it. Now, as with during the course of the immune response, the antibody response changes and the determinant starts spreading. That means it enlarges and your antibody response also enlarges. During this process, it is possible that you generate some cross reactive antibodies against self. Finally, regulatory T cells. Now, by and large, one of the main mechanisms by which autoimmunity is kept under check is by regulatory T cells. In fact, what has been shown is that and we covered a bit of it during our course on T cell subsets, that if you remove regulatory T cells, the amount of autoimmunity increases, because so the basic point is that there is a basal level that our immune system is not that perfect that we cannot generate a completely foolproof system. So, there is basal levels of autoimmunity, but that is kept in check because of the regulatory T cells. So, only after that is overcome that you are able to generate an immune response. So, the generation of an immune response therefore must be accompanied by severe inflammatory reactions, which will overcome the inhibition by the Tregs. So, by and large, basal immunity or autoimmunity is kept in check by regulatory T cells, and we had discussed this part, and it is a very important aspect of Tregs and autoimmunity sort of go hand in hand. Okay. So, we will discuss some other aspects. So, among the several factors affecting autoimmunity, again you can have two main groups. One is you have single gene disorders, and B you have the other is the complex traits where multiple loci and multiple factors are involved. In terms of single gene disorders, the most important one is are mutations in FASL or the death receptor, or mutations occurring in the death receptor pathway, for example certain caspases. And this aspect was covered very well in our course on T cell differentiation selection. Over here what happens is, if there is a mutation in the death receptor like the FAS receptor or the FAS ligand, it results in what is known as the autoimmune lymphoproliferative syndrome. So, what is seen over here is that the normal process by which death sort of removes these T cells is not taking place. Where the death pathway removes these T cells is not taking place, as a result of which they accumulate. So, you have, that is why the word lymphoproliferation, because they proliferate, their lymph nodes are bigger, their spleen is much bigger, because these cells are accumulate, and because they accumulate they cause this autoimmune lymphoproliferative syndrome. However, most autoimmune diseases are due to complex traits, that is multiple factors. And what are some of these multiple factors? The first is genetic factors. These are mutations or polymorphisms in multiple genes, and that can occur in different loci, and we will discuss these different genetic factors in for example in diabetes, where it was shown that MHC is important, but also the amount of insulin that is produced is important. You also have molecules like CTLA4 which play an important role in diabetes. So, again, because that is a complex trait, because you have different factors being involved in the actual generation of a disease. You also have environmental factors. We talked about pathogen exposure. Maybe there is some cross reactive a molecule between the pathogen or a microbe with self molecules, and the process of generation of an immune response against this, there is some cross reactive proteins. You generate response against cross reactive proteins, which results in disease. You have abnormal innate responses, or for example you have decreased thymic expression of self antigens. You also have reduced activation thresholds. Now, here the strength of a signal is important, because you have these self-reactive lymphocytes. Now, if for example, the lymphocytes see something with greater avidity, you would generate a reaction and maybe that would get eliminated. However, if the reaction is of much slower it's a low affinity antigen, so the reaction would be there, it would keep these lymphocytes, but it would generate responses against cross reactive. That is always a possibility, which may increases chances of autoimmunity. And you have decreased inactivation of self-reactive thymocytes. For some reason you have inactivation of these self-reactive thymocytes, and we have seen this case, especially when we were studying our on the class on thymic differentiation, where you have AIRE is a gene which is expressed in the thymus, and which is important in terms of expression of peripheral antigens, so that T cells that recognize these peripheral antigens are eliminated from different tissues. And in case you have mice or humans that lack AIRE, then you have this higher amounts of autoimmunity. So AIRE is a good example of that, which controls the expression of peripheral antigens in the thymus, and in the absence of that, you generate autoimmune receptors, which will cause disease subsequently after these cells move into the periphery. You also have other factors, for example, smoking, diet, pregnancy. These also affect autoimmunity. So, for example, what has been found is during pregnancy, for example, there is some sort of a suppression of autoimmunity features. So, that sort of helps. Perhaps that is accompanied as overall response to other antigens may be going down. Especially, remember, the fetus is also considered as a sort of an antigen. So, perhaps during pregnancy there is a lowering of these responses to allow the pregnancy to fully take place, and so that the baby is born, but as a consequence of this, autoimmunity features also go down. Smoking also seems to have a negative effect, which means it increases chances of these immune reactions and cause increased inflammation. So that would correlate in a sort of a negative sort of way, whereas pregnancy sort of suppresses these autoimmunity features. Okay. So, we will consider the different aspects that we studied. So, what are the different ways by which these could occur? So, in terms of tissues, you can have the antigenic self-antigen variants in different tissues, perhaps which may generate autoimmune reaction. You have expression levels, as I mentioned. In case of diabetes, you have insulin. The amount of insulin that is produced is important in, again, generation of the manifestation of diabetes, localization of tissue specific antigens, and then post translational modification. With respect to antigens and their expression in tissues, there are different factors that are involved, which are listed down here. With respect to APCs, you have MHC variants. Now, remember, MHC variants, MHC molecules are polymorphic, and they will have different affinity for different peptides. So, depending on the type of MHC that you express, it might have an effect. You have antigen processing and presentation. Remember, we discussed these aspects. You have the MHC, the proteasome components. These all may contribute to differences, and in class 2 you have the DM molecule and so on, which would again sort of apart from MHC, you have other components which might help result in variants or in different kinds of peptides that are sitting on MHC molecules, which will have implications in generation of a T cell response. And then you also have efficacy of antigen processing. Now, with respect to T cells, which are really the key over here, you have selection of the T cell receptors, the type of T cell receptors that are selected play obviously an important role because it would depend on the amount of cross-reactive ones that are generated. Regulation of T cell subsets, very important aspect. Because the T helper differentiation phenotype plays a critical role, and as we will see is that there is no real correlate as to these as to what happens, because in some cases you generate T helper type 1 responses, T helper type 2 responses, and in some cases beneficial in some but hurtful in others. So, there is no generalization about Th1 and Th2 responses in terms of autoimmunity. And in terms of EAE, as will be seen, the T helper 17 responses play an important role. Modulation of TCR activation, I had talked about the strength of signal playing an important role over here. High strength of signal, T cells respond strongly, you generate you generate a good reaction, and often it might result in elimination. However, with low strength of signal, the T cells are there and it will help generating against cross-reactive antigens. You have co-stimulatory receptors and ligands, expression of CD80, 86, and then subsequent ones like ICOS and the program death receptors. These all play an important role in this process and actually take part in autoimmunity. That is something that we will study in the next class. Okay, with respect to the genetics of autoimmunity, we have the MHC molecules. As I've clearly stated, MHC molecules play a very important role in this case, and I've given examples of this, and non-MHC genes. The one of the most important ones is AIRE, and this is with thymic selection. This is something that I had covered, and you must look this up. Genes associated with antigen clearance. Remember, antigen antibody complexes are recognized by complement, and which results in lysis of cells. It might also cause greater tissue damage. So, complement proteins are clearly important. Genes involved in tolerance induction. Fas-Fas-Cell is clearly important. So, if you have mutations in Fas-Fas-Cell, it results in lymphoproliferative phenotype. Also, if you have CTLA4 lacking mice, you have seen autoimmune phenotype, because the CD4 positive cells go haywire. They proliferate like crazy because there is no break to sort of attenuate their activation, and consequently it results in greater autoimmunity. Now, with respect to MHC, I have said that it can either be beneficial in some cases or can be harmful in other cases. Now, you can see that there is a whole list of molecules or the variants of MHC. For example, HLA-B27 is associated with spondylitis, very high association. HLA-B27 is also associated with uveitis. Now, with respect to type 1 diabetes, you have association with DR3, DR4. Now, you will remember that these DR molecules are MHC class 2 molecules. With rheumatoid arthritis, again you have association with DR4, multiple sclerosis with DR2, and then you have Graves' disease. Now, in Graves' disease, what happens is you have higher amounts of the thyroid hormones T3 and T4 being produced. Now, why are higher amounts produced? That is because you have antibodies to the TSH receptors, and these antibodies sort of stimulate the TSH receptors. So, they bind to the TSH receptors, stimulate it, and this stimulation results in higher production of thyroid stimulating hormone, which will go on and stimulate the higher production of T3 and T4, and as a consequence of which, if you have higher amounts of T3, T4, it results in increased basal metabolism, which will have its effects. That is an important aspect that needs to be considered. So, it has effects in terms of disease phenotype. I mentioned the example of regulatory T cells that play such an important role, and that is what is shown over here. If you thymectomize in day 3 thymectomy is done in this case, or in the T cell deficient mice, if you inject these cells, these results in gastritis or thyroiditis, and this is because of the lack or reduced numbers of regulatory T cells. Now, however, if you give these cells, and you remember from the previous class that we had discussed, the Treg phenotype is CD25 plus CD4 positive, and then you are able to block this generation of autoimmune diseases. So, clearly there is a big link between regulatory T cells and autoimmunity, and we have to thank Sakaguchi, who was the discoverer of the T regulatory cells, and because that has certainly informed or that has played a major role in our understanding of autoimmunity. Now, autoimmune T cells have been covered in the past class, but I will briefly quickly go over it. The number of CD4 positive, CD25 positive Tregs are present in small numbers, 1 to 10% in the thymus and lymph nodes. Now, the key thing over here is the expression of a transcription factor known as FOXP3. And in patients that lack FOXP3, it results in a disease known as IPEX, which is immune dysfunction. So, they have multiple disease phenotypes: immune dysfunction, polyendocrinopathy, enteropathy, it's X-linked, and you see similar phenotypes in mice that lack FOXP3, which is defined by the mutation known as scurfy, because that is how they look. Now, apart from FOXP3, just to keep regulatory T cells, just for the survival and maintenance of regulatory T cells, IL-2 and IL-2 receptor alpha is required. So, if you have mice that are mutants in IL-2 or CD25, then you again see autoimmune phenotype, and that is because of the lowered numbers of T regulatory cells. So, clearly regulatory T cells, there is a big link between regulatory T cells and autoimmunity, and the different genes that are involved over here, FOXP3 because that is the key transcription factors, and IL-2 and IL-2 receptor, which play an important role. Now, we had covered different T helper differentiation pathways, and you should be very well aware about the Th1, Th2, Th17 pathways. Now, as mentioned previously, that these T helper phenotypes are there, and they vary with different autoimmune diseases. However, there is no generalization can be made, because for different diseases we see Th1 playing a beneficial role or a harmful role. So, while clearly cytokines are modulated in different autoimmune diseases, in terms of the functional roles they vary. So, one has to look at each autoimmune disease and try and determine what is responsible or what is playing a functional role in that in these scenarios. In case of Th17, there is an association with experimental autoimmune encephalitis, and that is something that we will study a little bit later. So, in the first now what we will do is we will study different examples of autoimmune disease, because I think that is very important for students. So, the first one that we will study is the autoimmune lymphoproliferative syndrome. We have already covered this. These results in mutations in FAS, FAS-L, or maybe other mutations in the death receptor pathway, which could be caspases, but the main ones, mutations that are obviously uncovered, are ones in the death receptor ligand, and in humans it is known as the Kanail-Smith syndrome. This results in large increase in size of the lymphoid organs. You have increase in the double negatives, hypergammaglobulinemia. In the mouse model is the LPR GLD, and what is interesting is LPR is lymphoproliferative, GLD is the generalized lymphoproliferative disease. This is the FAS, LPR is the FAS mutation in the FAS receptor, GLD is mutation in the FAS ligand. And the phenotypes that are seen both in humans as well as mice are somewhat similar, and basically it involves failure to delete autoreactive T cells, which result in this condition. The second disease is the systemic lupus erythematosus. As I mentioned, that women are more likely to come down with this disease, and it manifests itself after they turn about 25. It's a systemic inflammatory disease, and what happens over here, you have the antigen antibody complexes or the immune complexes depositing themselves on tissues, resulting in inflammation. So, you have inflammation in different parts of the body, joints, skin, kidney. Here what is important in SLE is that you have antibodies against nuclear antigens, in fact that is a diagnostic feature of SLE. So once you have deposition of these antigen antibody complexes, they are coupled with complement activation, and these cause damage, as I mentioned, and this especially this once the kidney function is affected because of accumulation of these large amounts of antigen antibody complexes followed by complement activation, then the patient is at great risk. What is known is the nuclear antigens, especially Rho and La, are the important ones, and they appear as blebs on the surface of apoptotic cells, and the lot of the antibody response is against these nuclear antigens. Now T cells are clearly playing an important role, because if the CD4 numbers go down, as has been seen in case of HIV in patients, then it leads to lowering of SLE symptoms. So clearly T cells play an important role over here. The mice model that have been used are the NZB and the NZB, NZD, ZW F1 mice. So this is the F1 mice, and this is NZB. Now what is interesting to note is the NZW mice by themselves are novel, but the F1 along with NZB and the NZB themselves are show LPR phenotype. What has been seen over here is that there is an increased Th2 profile. In fact, there is high IL-10 and IL-6, and in fact IL-4 transgenic mice, that is those mice expressing a lot of IL-4, develop SLE on their own, especially anti-nuclear antibodies, and renal disease is observed. In terms of laboratory, one of the distinguishing features of SLE is this generation of anti-nuclear antibodies, and that is what is often used. You have methods to detect these, and which is a diagnostic which has diagnostic benefit, and the way this is done, you have animal or human cells fixed to the slide, and with the patient serum you incubate them, wash off, and then you stain with the anti-human globulin linked to a fluorescent tag, and then you are able to check for, especially if you have fluorescent anti-nuclear antibody that is seen. So the important feature of this is with SLE is the anti-nuclear antibodies that are seen. Now in terms of the different generation of disease in case of SLE, there are three main ones. First is it starts off with immune dysregulation, and then you have, obviously you need to start off with immune dysregulation because that is how you generate the response, you have the response going. Then you have immunity against self, and then there are manifestations of autoimmune invasion, and finally you have a hugely inflammatory scenario that is developed. And once you have that huge inflammatory scenario, it becomes difficult to control the disease. So it is easier to control the disease in the first two steps, and that is an important aspect. So that we will see it over here. You have immune dysregulation, you have the autoreactive T cell activation, which will go on and then turn on the B cell activation. Then subsequently you have tissue inflammation, you have autoantibody production, and then you have different cytokines that are turned on, because now what you have is an inflammatory scenario. Then you have impaired tissue responses, because now because of the excessive inflammatory reaction, your organ and tissue functions are getting compromised. They are not able to repair themselves as well. You have tissue fibrosis, you have organ damage, and then overall you have real manifestation and a full blown systemic lupus erythematosus going on. And how does one control these diseases? That is again something that we will be discussing, and again for different diseases you have different strategies, and by and large there are some common ways by which these are taken care. The third disease that we will go over is rheumatoid arthritis, and arthritis, as you know, is inflammation of the joints. The major symptoms are joint pain, inflammation, stiffness, because your joint function is affected. What is interesting to note is that you see that it is an immune reaction, because from these joints, if you take the fluid, they will contain high amounts of the cytokines IL-1, IL-6, TNF, because these are being produced by the immune cells. As was mentioned previously, rheumatoid arthritis is linked to MHC. The mouse model is collagen-induced arthritis, where you take type 2 collagen and you mix it along with Complete Freund's adjuvant, and then this generates an injection of this generates a disease. Now, let me ask students a question: why is it that you need to inject with Complete Freund's adjuvant? Now, this is something that we had discussed in the first classes on innate immunity, because what happens over here, collagen is a self protein. And if you want to generate an inflammatory reaction, if you want to generate a good immune reaction, it needs to be inflammatory in nature. So, the way that is often done is to mix it along with Mycobacteria, and you are able, once you are able to do it with these dead Mycobacteria, the adjuvant potency is increased, and you are able to generate a good reaction. In this case, this reaction leads on to the breakdown of tolerance, and it will generate autoimmune disease. So, this is a mouse model, and these are useful because when people study for different therapies so on, these become useful. In terms of RA, there is a link between tumor necrosis factor and rheumatoid arthritis. So, mice that are transgenic, again producing large amounts of tumor necrosis factor, develop spontaneous arthritis. So, clearly this cytokine is responsible in a large part for arthritis. So, consequently, if you treat patients with anti-TNF or anti-TNF receptor, then it reduces inflammation. And in fact, this is a clinically approved form of therapy. Now, what is interesting is TNF is also important in terms of immunity. So, once you start lowering TNF, it has other effects, and one of the effects is that you see increased susceptibility to Mycobacterium tuberculosis. So, very interesting scenario over here. I think for immunologists, it is a very important aspect. So, when you tweak or when you try and use therapeutic regimes, especially targeting important cytokines like TNF, you will have some consequences of it. So, one has to be careful with these aspects of the immune system, because what you are doing is you are reducing important cytokine. So, obviously, and this cytokine is protective. So, the pathogens, especially Mycobacterium tuberculosis, takes advantage of this situation and tends to take over these patients. So, one has to be careful about these aspects. Now, with respect to RA, you have treatment with immunosuppressive drugs, or the ones that suppress the proliferation of immune cells, and this again helps. This is again part of a regime that is used against autoimmune diseases. Okay. One of the diagnostic features of rheumatoid arthritis is detection of rheumatoid factor. Now, what is rheumatoid factor? Rheumatoid factor is actually a IgM antibody, and which is detected against the Fc portion of Ig molecules. So, it is an anti-antibody in that sense. So, detection of rheumatoid factor, the rheumatoid factor levels increases with rheumatoid arthritis and also along with some other autoimmune diseases, but its correlation with RA is very good, and it is used in terms of diagnosis. Now, as was mentioned, immune complexes activate complement followed by the inflammatory reaction, and this will follow by damage, and often what is seen over here in case of rheumatoid arthritis, you have destruction of cartilage. Remember, cartilage is what buffers the bone tissue, and it is followed by once cartilage is disturbed, you have proliferation of cells that try and take over, which is known as the pannus. But pannus, unfortunately, is the abnormal growth of these cells, and which is not particularly good. Now, in case of the pathophysiology, you have swelling of the synovial lining, you have rapid division of cells, which is what gives rise to pannus, and then you have cytokine release, infiltration of leukocytes, destruction of bone and cartilage. So, not a good scenario, and all these contribute to arthritis, which is why there is pain, there is swelling, there is stiffness, and so on. The next disease that we will study is insulin dependent diabetes. As was mentioned over here, that over here that you have destruction of the beta cells of the pancreas. Now over here HLA plays an important role, and people have shown that it contributes to 40% to the risk factor. You have different HLA molecules that are protective or that appear to make you more susceptible to disease. What is interesting in mice, you have these mice known as non-obese diabetic mice or NOD mice. These are known. Now NOD mice have a very interesting MHC class 2, and there the haplotype is G7. Over here the MHC class 2 molecule, it contains histidine at 56 and serine at 57. What has been seen is in all of the strains which are not as susceptible, they contain an aspartate at 57 instead of a serine. And in fact what has been shown is that if you contain a serine, valine or alanine at position 57, it is linked with susceptibility. On the other hand, aspartate is linked with resistance. So you can see a single residue is important in determining in MHC class 2 is important in determining susceptibility to diabetes or resistance. So very important aspect. Again, the inflammatory filtrate that is seen especially in the pancreas, it contains primarily of CD8 positive cells, different types of B cells. Again, there is a lot of killing, so you have these cytolytic ones that are generated, CD4 positive cells, macrophages and so on. One of the antigens that has been found that generates a lot of autoantibodies is glutamate decarboxylase. And along with MHC, what are some other molecules that are linked with disease progression? Remember, diabetes is a complex trait, is a complex disease, so you have different genes that are involved, one of which is insulin. Apart from MHC, apart from MHC class 2, you have insulin. So the number of repeats at the 5' end is important in terms of expression. So that is important. There is a lymphocyte specific tyrosine phosphatase, LIP or PEP, which is also important. And then you have CTLA4, which has also been shown. So these together, these 4 genes play important in determining resistance or susceptibility to diabetes. The next disease that we will study is multiple sclerosis. So what is multiple sclerosis? So over here you have a T cell response and that generates lesions in the brain. So you have lesions in the brain which show up, and because of this you have the myelin sheath gets destroyed, and you have demyelination, and it forms these plaques in the brain and spinal cord. And again, this is an inflammatory response. The T cells are reactive to myelin basic protein. In fact, in the model that we have often discussed, EAE, which is the experimental allergic encephalomyelitis, over here myelin basic protein is mixed along with CFA to generate multiple sclerosis. It is mediated again by CD4 positive cells, and again, as IL-17 has been shown to be playing an important role. Now in case of multiple sclerosis, what has been found is interferon beta has been found to slower the disease. And how does it slow down multiple sclerosis? Because it has been shown to have an anti-proliferative effect on T cells, and sort of helps, in fact, so interferon beta is therapeutically used to slow down multiple sclerosis. The other disease that we will study is inflammatory bowel disease, and so this is a very painful disease because it causes a lot of anguish in patients, and there are 2 main, in fact diarrhea is the most common manifestation of it, but there are 2 main ones. One is colitis, which is inflammation of the bowel, which is the end of the large intestine as such. The other is Crohn's disease, where inflammation can result anywhere in the gastrointestinal tract. And together these form a part of IBD or inflammatory bowel disease. In terms of Crohn's disease, there is diarrhea, pain, there is narrowness of the gut lumen, and so it leads to bowel obstruction, abscess formation, and fistula, which is actually an abnormal connection between the skin and internal organs. You have colitis on the other hand as severe diarrhea, blood loss, it results in what is known as megacolon formation or the dilation, perforation. So, a very painful disease. Over here what has been shown is that interferon gamma plays an important role. So, treating mice at least with anti-interferon gamma has been shown to be useful. IL-10, again IL-10 sort of is important over here in lowering disease. And if in mice that lack IL-10, these develop colitis under conventional housing conditions. Now, Crohn's disease, there is a link between a particular gene known as NOD2. Now, we had discussed NOD2 again in the innate immunity class. The NOD2 stands for the nucleotide binding oligomerization domain 2. It is part of the pattern recognizing receptors. Remember, you have the TLRs which are present on the surface and the NODs which are intracellular pattern recognizing receptors. So, one of them is NOD2. It sort of it recognizes the murine the bacterial peptidoglycan, and so that plays an important role in generation of responses. So, NOD2, there is a link between NOD2 and Crohn's disease. Now, we mentioned that what are the different ways by which you can diagnose autoimmune diseases. There are general tests. So, you can have a C-reactive protein which is an inflammatory marker. You have autoantibody titers, anti-DNA in case of SLE, nuclear antigens. You also have the presence of rheumatoid factor level goes up, especially in case of rheumatoid arthritis. So, you have these different ELISAs that can be done. You also have specific ones. For example, neurological examination will tell us whether there are lesions in the brain, especially with respect to multiple sclerosis. In case of diabetes, fasting glucose is one of the easiest ways by which it can be determined. Remember, diabetes is a major problem in India. With increasingly population is coming, increasing numbers are coming down with diabetes. So, one has to be a little bit careful about these, and so now, how about the control of autoimmune diseases? Now, the anti-inflammatory drugs. So, see, one aspect that people need to understand is that once you have autoimmune, it becomes difficult to manipulate, especially at the end stage. So, the easier thing that can be done is one has to manage autoimmunity, and in order to manage autoimmunity, there are different ways. One is to reduce inflammation. So, often corticosteroids are used, but remember the steroid treatment results in other effects. So, the non-steroidal anti-inflammatory drugs are often tried initially. In case they work, corticosteroids, cortisol might be used. Cortisol is much more effective, but it has side effects. The other way is to reduce cellular proliferation, especially in rheumatoid arthritis. In these cases, you have lot of immune cell proliferation. So, you can reduce these cellular proliferation using these drugs such as methotrexate. You have T cell responses again. You can suppress T cell activation using cyclosporin, tacrolimus. These, remember, cyclosporin, tacrolimus both are important in acting on the NF-AT pathway. So, that is certainly used, and then in case of multiple sclerosis, you have treatment with the interferon beta. So, we will just briefly go over some of the highlights of today's class. The first important thing that we need to discuss is that by and large the immune system works very well, but only in a minority of cases it actually results in autoimmune disease. This is not to say that the immune system is perfect. We do have autoimmune cells within us. In the process of generating an immune response, perhaps some autoimmune cells are generated, but those do not take over and result in disease. It does so only in a minority of cases. By and large, it works quite well, and there are mechanisms in place to keep these cells in check. the primary cell that plays an important role in this case is your regulatory T cells over here. Now, in some cases, perhaps due to environmental factors, perhaps due to mutations in genes, you have manifestation of autoimmune diseases, and we had discussed here the roles of MHC, especially MHC class II molecules in predisposing either susceptibility or resistance to different autoimmune diseases. Regulatory T cells obviously play an important role, and the role of FOXP3, IL-2 receptor cannot be overemphasized. And then you have the Th1, Th2, Th17 cells which play an important role over here. So, together you have different factors that seem to play a role. What we have also done in this class is to study different examples of autoimmune diseases, and they all differ in their manifestations and in their reasons. So, for example, in SLE, the major diagnostic feature is your generation of antibodies against nuclear antigens, whereas that in type 1 diabetes you have destruction of the pancreatic beta cells, and in case of multiple sclerosis you have primarily a T cell response that recognizes myelin basic protein, and that causes lesions or plaques in the brain and spinal cord. And so, there are different ways to diagnose these autoimmune diseases. One was ELISA is a very good tool. You can check for rheumatoid factor in case of autoimmune, or in case of rheumatoid arthritis. One can check for anti-nuclear antibodies in case of SLE. You can check for general inflammatory markers in the C-reactive protein. You also check for disease manifestations of specific ones. So, for example, fasting blood glucose levels in case of diabetes. So, in terms of cure, there are the way that this is done is you can reduce inflammation by using non-steroidal anti-inflammatory agents. Usually that is tried, and then subsequently cortisol therapy is done because of side effects. Then you can prevent the proliferation of immune cells. As I said, methotrexate is often used because that sort of reduces. Then you have in case of T cell specific diseases, you can reduce T cell activation by using agents such as tacrolimus, cyclosporin, which will affect the IL-2 pathway, which will result in blocking T cell activation because of blocking the IL-2 pathway. And in cases like multiple sclerosis, you can use interferon beta, which has been shown to be extremely useful in slowing down the multiple sclerosis. Overall, what this class has dealt with, actually it's a case of a rebel scenario in which autoimmunity results by certain rebels. So, the question is why does this occur, and we have seen different factors that are involved in place. But there are, and one has to emphasize that autoimmunity, it's impossible to get rid of autoimmunity. One has to learn to deal with autoimmunity and try to keep it in check, because once autoimmunity is completely full blown, it becomes very difficult to control and contain. So, therefore, during the initial stages or initial manifestations of autoimmunity, these need to be diagnosed as early as possible, and need to be controlled, and there are different therapeutic mechanisms in place that can sort of help us control autoimmunity. Further studies in this area may help us understand further factors and come up with potential therapeutic targets which will help us control autoimmune diseases in a much better fashion. Thank you.